Wow. Okay. I'm going to focus my remarks or frame my remarks in today's historical context because I do believe that caffeine has been widely studied, understood. I think what we need more data around is the new ways in which new products are being consumed. So when I talk about caffeine, that's what I'm talking about. So the first and most basic data needed are estimates of prevalence of use and possible health hazards. The data presented from the ILSI study and the analysis of NHANES didn't really inform about the proportion of the population who used in the past month or the past year, which are standard items that would be captured in other federally sponsored surveillance systems. The most widely used such survey of American school children began asking about energy drinks in 2010. This is called Monitoring the Future. It's NIH sponsored and it's been around since 1975. And we spent a lot of taxpayer dollars on this survey, so we should leverage its opportunities. The only reported results from that survey was in a press release from the authors that stated in 2011, in answer to the question about how many energy drinks do you drink per day on average, the proportions indicating any recent use were 35% of 8th graders and 29% of both 10th and 12th graders. But interestingly, the corresponding table was not in the full report. So I think it would be helpful specifically to contact Dr. Johnston at the University of Michigan to learn more about their findings. The methods vary widely among these surveys and in part might explain their disparate findings. So I'll volunteer my expertise in measurement to help sort out such discrepancies if the IOM believes that might be useful. And multiple methods are used to derive a clearer understanding of patterns of use. So what is the proportion of the population that used a particular caffeine product in the past year, in the past month? What's the quantity and frequency of use? What's the maximal amount consumed, I think was brought up. How do these estimates vary by age? Very important. Further, we need to understand the proportion of children with known underlying cardiovascular medical conditions who are being exposed to high levels of caffeine, because this is important to gauge our public health response. And in response to some physicians in the audience yesterday who indicated that they just weren't seeing patients who attributed their medical complaints to energy drinks, I would ask in return, how systematically are you asking about recent consumption of energy drinks when a patient, especially an adolescent patient, presents with cardiovascular symptoms? Better assessment and screening tools for busy physicians are needed to estimate the true proportion of cases that can be attributable to energy drink use. So in your response to your question, what kinds of data methods, I think we need to put forms in the hands of physicians who see patients with cardiovascular complications. This is a classic problem in epidemiologic surveillance. It's analogous to parent reports of children's alcohol consumption. They don't ask, and children don't tell. Bottom line is we need to start asking and reporting more systematically if we want to know. One of our charges was to assess the health impact of the total amount of caffeine ingestion from all sources. With regard to the overlap or substitution of different sources of caffeine in the population, I looked at our data from approximately 1,000 young adults in their 4th year of college, and we showed that 3.4% didn't use any form of caffeine, only 2.6% used energy drinks alone, but not coffee, soda, or tea. An additional 31% used coffee, soda, or tea, but not energy drinks. But the greatest proportion, 63% in the sample, almost 2/3, used both energy drinks and another type of caffeinated beverage. So these data suggest, contrary to what was suggested yesterday, that energy drinks, at least in young adults, are consumed in addition to rather than replacing traditional caffeinated beverages. Finally, how best can you evaluate the magnitude of health consequences? For this, many rely on tip of the iceberg data sets that are available that measure the most severe consequences. Federally sponsored surveillance of emergency department admissions, poison control, the FDA adverse event reporting systems are some examples. But many individuals in the population aren't even aware that they can call poison control centers or that the FDA has an adverse event reporting system. So while these are useful in providing these safety signals of what might be below the surface, they hugely underestimate the true proportion of medical complications that might be associated with the consumption of any one substance. More preferably, proactively asking questions of samples of consumers about their experiences, akin to the required and rigorous methods for adverse event reporting for pharmaceuticals and clinical trials, would be required to estimate the proportion of individuals experiencing health problems. Many other data gaps have been identified over the past 24 hours. I'm sure my colleagues will cover that, including research to demonstrate safety of current product formulations involving higher doses among adolescents, interactions with other ingredients, medications in both adolescents and young adults. The use of highly caffeinated beverages before and during exercise, since many are encouraged, especially young people, to use these products in combination with sports activities. And finally, basic data on pharmacokinetics under different circumstances of consumption, hot, cold, and among individuals with varying sensitivities or genetic differences. Thanks again, and I look forward to being helpful in any way I can.